Hello, my name is Gian Luca Burci. I'm an adjunct professor of international law here at the Graduate Institute. In the second lecture, I would like to go a bit more in depth on a particular aspect of pandemic preparedness and response, and including of the design of the international health regulations. And I'll call them again by the acronym IHR for brevity. This is an aspect that has attracted much attention during the COVID-19 pandemic, but it's a long-standing problem. And that has to do with the capacity of the public health systems and the healthcare system of states in detecting, assessing, and containing and responding to outbreaks or diseases. This is what in the WHO jargon we call it core capacities. And why are these important? Because historically, as explained in the first lecture, there has been a shift in the sort of philosophy of global health security away from the borders to inside the state as the place, the locus, where you detect and contain diseases. In the past, it was all about the border. It was about the crossing point. It was about the port. It was about the airport. These remain important, of course, but in a globalized system of risk assessment and management, where you don't know where the next health risk will come from, what happens inside a state is as important, if not more important, than what happens at the border. And so inside the state means the capacity that the state has to perform the functions that I just described. So the existential importance of health system is something the WHO has understood and has, in a way, advocated for a very long time. Not only response to emergencies, but also because no system of disease-based system, in looking at influenza, looking at malaria, looking at tuberculosis in isolation, will be effective if it's not connected to national public health systems that are well-financed, that are well-designed, that are resilient, that are sustainable, but also that are equitable and they're inclusive and guarantee access to basically all population, at least to basic care. That's what WHO call universal health coverage. So it's really all linked together. It's something that is not just relevant during an emergency, it's always relevant. But it becomes particularly important at time of emergencies because there's a very clear link that sometimes we forget between what happens inside a state and the implication of what the state is doing inside its territory for other states. Go back to early 2020 and remember what happened in many countries, like in Western Europe, in Italy, in France, in Spain. And so that, from a legal point of view, is a very innovative aspect of the international health regulations, because in particular in Article 5, Article 13, if you want to look it up for yourself, and Annex 1 of the IHR, you clearly see obligations of state to build up and maintain, again, core capacities to do fundamentally two things. The first is surveillance and detection. So basically something is happening. What is it? I try to assess it and I will notify WHO and other states. The second is response. So we have an outbreak. How do we contain it? How do we respond? And the response, again, will be very important in preventing the spread internationally, which is a fundamental purpose of what the IHR is about and what WHO's role is about. And so what are we talking about? What are these core capacities? And again, I invite you, if you're interested, to look at Annex 1 of the International Health Regulation. We are talking about issues like a surveillance system. Are we able to detect an outbreak, sentinel posts, or even hospitals, laboratory capacities, referral between different levels of the state, civil protection in case of an emergency, in case of a disaster, has been activated in many countries during COVID, stockpiles of equipment, of basic medicine, of protective equipment, of masks, logistics, hospital emergency service that allow hospitals not to collapse under the onslaught of a pandemic, but to be able to continue to treat other diseases. Inspection system, if you want to inspect, for example, means of transport, airplanes, ships, trucks, financing. Are you able to mobilize financial resources during an emergency and so on? So these are all things that are crucial in preventing and responding to a pandemic. And so from a legal point of view, if you think of it, it's a very ambitious and very intrusive obligation because basically countries have accepted an obligation vis-à-vis other states to how they manage their own healthcare system, their own hospitals, their own emergency, their own civil protection. And that's not something that you can take for granted. It is not unprecedented because there are other international treaties, international legal regime that impose obligation on states in this respect. One is human rights, because under what we call the right to health, which is a human right codified in many treaties, states have to make sure that they can offer certain services, certain goods, and so on. So they have an obligation of managing the public health system in a certain way. And the other is economic law, trading services, for example. Many states have opened the public health system to liberalization, to accept medical tourism, telemedicine, and so on. So also in these cases, it creates obligation and constraints to what they do in the public health system. But these obligations under the IHR are much more intrusive. This issue of core capacities has been a challenge for a long time, since the beginning of the revised IHR in 2007. So it's not something new to COVID. But what some of the challenges, what has COVID revealed or confirmed, and what are states, what is international community trying to do about it? And obviously here you have a lot of experience that member states have acquired in these last 2 years, sometimes in bitter lessons, I must say, at the cost of a lot of human lives, but also the policy discussion that had taken place in policy networks like the G7, G20, in organizations like the United Nations, WHO, European Union, African Union, but also in these independent reviews that have taken place in the last couple of years. So many lessons have been learned. The first is that the ability of states to perform their core capacities is not just a development issue. Go back to Ebola in 2014. The in a way, the common wisdom was that developing countries will not be able to manage outbreaks, developing countries will be able. Look how COVID-19 has changed this parameter. Back in 2020, Western European states, North American states performed worse than sub-Saharan African states. So in part is the level of resources or development, if you want, but it's also the economic and social model the states have acquired in managing the public health system. And so underinvestment in primary healthcare, excessive privatization, the dismantling the system of public healthcare and so on has proved a big problem in sustaining the shock of a pandemic. Everybody rushed to the hospitals, and the hospitals became a super spreader event. There was no filter, and there was no resilience. So that was a big lesson of COVID. That's a very difficult lesson for many countries that by now are very advanced in privatizing or investing in secondary and tertiary healthcare. That we really have to look carefully at how to reconcile the model with the need to be able to sustain future pandemics. The second is the complexity of core capacities, not just hospitals. If you have an emergency of this nature, you're talking about emergency services, civil protection. Look at federal states, how different levels of the states have to work together, not across purposes. But also look at the zoonotic aspect of diseases jumping from animal to human. Here you need good veterinary services. You need a clear interface between human health and animal health. So it's this complexity that has led to a very clear call for elevating pandemic preparedness and response and the compliance with the IHR to the highest political level. They cannot remain the prerogative of Ministry of Health. They have to be on the desk of Prime Minister, or Trade Minister, or Finance Minister, and remain there, because only with that level of political leadership you can ensure that you have a coordinated response, that different ministries don't act across purposes, that there is a level of financing adequate to the situation, and so on. So that's a very important lesson. Financing, so that's obviously a big challenge. And that has to do not only with the typical call for we need an international system of financing. Yes, we do. But we need national investment at all levels of development. There is a clear sense that many countries are not investing enough in public health at all levels of development, even for least developed countries. So the national investment is very important. And as I explained also in more general terms in my first lecture, there is an open discussion, not an easy one, I must say, on devising a system of international financing that can really support national capacities. Probably WHO will never become a financing agency, but we are looking at the World Bank, we are looking at regional development banks, we are looking probably at new funds on having a sustainable and sometimes matching approach. You invest and we'll match your investment, or will give twice what you're investing. That's very much an open issue. And finally, one big challenge, and goes back to what I was explaining in my first lecture, is the lack in WHO and in the IHR system of a mechanism for compliance assessment, like we have in many other treaties, or what we call accountability. So what states have been doing in core capacity has been largely based on self-assessment. They assess themselves, and then they report on an annual basis to WHO. And it's very self-intuitive. The self-assessment can only go so far. And also, WHO presents a report every year to the Health Assembly, but it's a very macro report. It gives statistics, it gives percentages, it gives total numbers. It does not look at individualized assessment. There's no naming and shaming. There's no possibility of saying country A has these challenges. So that's something that absolutely has to change. And there's a growing awareness of this gap. So things have been happening in WHO and outside of WHO that have improved the situation to a certain extent. Outside of WHO, the United States really led to the creation of what we call the Global Health Security Agenda, which is a network of about 60 states. There is a primary purpose, helping countries improving their core capacity. This led to quite some ambivalence at the beginning, because it was seen as sidelining WHO, basically taking a WHO function out of WHO in a political network of states. But I think it has proved its value. WHO has been supporting self-evaluation. For example, those of you that have been following more this issue will be familiar with what we call joint external evaluations, basically asking countries to assess their own capacities according to certain parameters, and then deploying teams of experts to sit together with the government and coming to a joint assessment. What is working, what is not working well, what is working very poorly. And developing a scorecard of green, yellow, and red that first helps the country prioritizing its investment, and second helps developing countries going to donors and basically saying, this is what is not working, please help us in ABC. I think it is a lot of added value. The drawback, it is a voluntary initiative. States are not obliged to do that. And even though a large number of states have volunteered for this evaluation, other countries have not. And we cannot just rely on the goodwill of states. We need a system where every country is regularly assessed. WHO Secretariat, I think in the course of time, has done a very good work in putting out a lot of guidance documents, performing checklists, helping countries doing simulating an epidemic, simulating a pandemic, to see how countries respond, really not just on like a desktop exercise, but really having different countries coming together. And there is a clear call for remedying this gap in accountability. WHO is piloting right now with a number of countries a system similar to what the Human Rights Council has been doing for human rights, the Universal Periodic Review. And Dr. Tedros, the Director General of WHO, has proposed Universal Health Periodic Review. Again, it's been sort of tested, field tested with a number of countries, and it should include also the core capacities, the ability of states to do what I described during this lecture. There are other proposals on the table. For example, as explained in the first lecture, the United States has proposed quite a number of amendments to the IHR. And one of these amendments consists in the establishment of a compliance committee in WHO. They should really look more in depth at issues of non-compliance, not necessarily in accusing states, but working with states in understanding their challenges, their problems, their lack of resources, and so on. And that, if that comes to the fore, that sees the light of day, I think it will be a big step forward. So, as I stated, this is a long-term problem. It will not be solved overnight. Things have improved to a certain extent, but it's very much a work in progress. It will require a lot of leadership. I think the positive message with which I would like to finish this lecture is that there is convergence on the priorities. And the priorities are investing in prevention, sustainable financing, political leadership, and mutual accountability. If there is really clear political direction in this way, I think we could improve to a certain extent what COVID has shown is a big gap.